All right. How's everybody doing? Joe Walsh, Aiden Rainey here. We're with the Master of Efficiency in TAVR, Andrei Pop. Andrei is on faculty with Edwards Lifesciences in the Benchmark program. He also runs the structural heart program at Alexian Brothers at Ascension in Chicago. And Andrei has been identified as one of the national leaders in TAVR efficiency. And I think we all, with our respective structural heart programs, struggle with this and how to have an efficient workflow, how to get TAVRs done in time so everyone goes home and sees their families before 4 or 5 o'clock. And we wanted to take some time with Andrei and just talk about how he's able to accomplish 7 TAVRs in a day by 3 o'clock. So Andrei, let's start by pulling up Andrei's TAVR workflow. So Andrei, can you take us through this, and then we can talk a little bit about some of the tactics you've used to achieve this remarkable efficiency?
Yeah, Andrei, first of all, I was amazed not just by the numbers and the timing, but the fact that you built out this whole grid, I think is really intelligent, and kind of get people to be on the same page. So yeah, maybe you could just kind of let us know how you started, how you got this, and what worked for you along the way.
So I think the way we came to this is that we became gradually more efficient in our TAVRs. And I think that when you're looking around the country at good TAVR programs, pretty much everybody takes less than 30 minutes skin to skin. I mean, that's never the delay, unless you're doing something crazy, unless you're doing a basilica or doing a transcaval, something like that. Doing the TAVR itself is not going to take that much time. The big question is what happens before the case, what happens after the case. And a lot of times, that's the time when the physician is out of the room and nobody knows what happens. And unless you interact with your team, you're going to come back frustrated and say, hey, why is this patient not ready? And so as we've increased our efficiency in the procedure, we also looked at everything that goes in before, after the procedure, and everything that happens not only to the patient, but everything that happens to the room. And basically, we've gotten to the point where the staff members come to us and say, you know what, we're efficient enough, we can take this up a notch. We can do another case this day, or we can do something else, or we can move a little bit faster. And I think it's really looking at a totality of the patient experience. And when I go around the country and I look at programs, there is tremendous variability in the way things are done. And it depends, first of all, where the patient comes. If the patient comes to a pre-surgical area that has other priorities and the TAVRs are not a big priority, it's going to be hard to have an on-time start. For me, the patient always comes to our cath lab holding area that is staffed by cath lab people that I control, and their only objective is to get that patient on the table on time. Then there's little things, how much needs to happen in that time between the moment the patient arrives to the moment the patient is on the table. And we try to get as much done in that time, but also as little as possible needs to be crammed in that time. So as an example, a big source of delay in many places is blood work and type and cross and all that kind of stuff. Well, we do the blood work and the type and cross a couple of days before. The patient goes to the blood bank, they get a ID band that they bring with them. And that way the blood is available right away. You'd never have any delays in the blood bank because they know this patient is coming. They know exactly what blood they need to have available. So that's an example of something that we've moved completely out of the pre-operative period, and we moved it before the patient comes to the hospital. On the other hand, when the patient comes in, they get an electrocardiogram, they get their chest shaved, and they get prepped, and anesthesia evaluates them. The whole chest prep and body prep is something that in a lot of places I see happening inside the procedure room, which makes no sense to me. It's, the time that you have in the procedure room is precious. I don't want hairs all over the operating, field. So having them shaved beforehand and prepped and coming straight to the table where they're only getting, betadine applied and then the draping put on saves a lot of time and makes the time in the procedure room move very fast. So I think you have to look literally at every aspect of the procedure and say, what can I get rid of? What can I move to outside the room? And if it's something that can be moved before the admission, do it that way.
Yeah.
So all those things are little things that make a big difference all put together.
I love it. And then, Andrei, talk a little bit about your turnover, because I think the on-time start is critical. Like when you think about TAVR efficiency, having an on-time start that everyone sticks to and minimizes delays is critical. Setting expectations with a table like this that you can disseminate to all of your staff and have accountability. But then I think you also do a lot of novel things in the turnaround time with your anesthesiologists and cleaning crews. Can you talk a little bit about that? Because if you look at this, procedure completion 7:55, transfer to holding 8:10, and you're sticking the groin half an hour later, I think that's pretty efficient turnaround time. And to follow up on that, is there a turnaround time people should target in terms of just the maximum level of efficiency?
So I think 15 minutes is about as close as I think you can cut it. We're still doing a solid prep. We're certainly not doing a surgical prep. We're not prepping the chest except for shaving it. But I think the way we do it is we, again, try to move everything to where it should belong logically. So basically, the moment that I take my gloves off, the technician comes from the left side of the table where they usually reside with the supplies. They come to the right side of the table. They start applying manual pressure, which they hold on for 15 minutes. And during that time, they also take a chest x-ray using the x-ray equipment. That's a step that basically saves us time afterwards because we're no longer dependent on having x-ray coming up to the floor and doing an x-ray. That patient is sitting on a table with somebody holding their groin, perfect time to check an x-ray. During the same time, another member of the team goes and checks Doppler pulses. The patient is still fully prepped. If there isn't a Doppler pulse, then I'm still around. I can come in, I can take a picture. But that eliminates the need for me to take a routine picture, which a lot of places I know still do. And in this 15 minutes, the rest of the team basically takes the room apart. They take all the equipment, they throw it away, they assemble the trash bags. And then by the time their patient is ready to roll off the table after they had a full neurologic exam, well, a limited neurologic exam done by the team, the anesthesiologist has already left and has gone to see the next patient. And as the patient rolls out of the room, the housekeeping person comes in and starts cleaning the room. And housekeeping doesn't do any of the heavy lifting of cleaning the tables because that's not really their expertise. They come and wipe everything, but they don't deal with any of our equipment. That's all done by the staff that has been in the room in the 15 minutes that the groin is being held. And then the moment the patient rolls out, they get to the holding area, they drop the patient, they sign out the patient to the holding area team, and then they move to the next patient, they pick up the next patient, and they return to the room. And in the time that they dropped off the patient, the anesthesiologist has already evaluated the next patient. So I think that's 15 minutes is about enough time to do all that. And I think that that's something very achievable.
Yeah.
Yeah, Andrei, we talked about just the cleaning. I know in my lab, sometimes we'll be waiting for a cleaning person. They'll say, okay, patient's out of the room, and then they call the cleaning and the cleaning person comes. But you have, it sounds like you've built it in so that they're not doing it step by step. Okay, like patient's out of the room, now we call cleaning. Then it's like they're ready.
So we did this before COVID, and it's one of the things that has resulted in the highest level of efficiencies for us. Is for many years we never had a cleaning person in the cath lab. We have 4 rooms, and the staff would clean themselves. And if it was a major bloodbath, we would call for housekeeping, and housekeeping would come whenever they could. And so we pushed and pushed and pushed, and we were able to finally hire a housekeeper. And in the hierarchy of hospital costs, the housekeeper is definitely at the bottom of the totem pole. And it blows my mind that people say, well, I can't afford the housekeeper, but I can afford to have 4 cath lab staff, which are each making probably $50 an hour, an anesthesiologist, a cardiologist, and a surgeon sitting on their hands, waiting for this housekeeper to come from somewhere else. You know, that's the easiest way to do it. Hire your own person, have them be there, help with every single case, and it's a good job for them. They like it. We treasure our housekeepers. They love working with us.
That's awesome,
Yeah.
dude. So funny how
Absolutely.
something so simple could have such an impact on whether you can do, 5 TAVRs in a day or 7. Just having a housekeeper come in is so true.
Yeah, and I mean, I kid you not. I mean, the housekeepers, they're full members of the team. We love having them around. They love being around us. I think we're probably the hospital department that dispenses the most free pizza and entertainment. So
Yeah.
they love working there,
And
Yeah,
so
and-
I think one question I have is, when you look at your own individual TAVR programs, you want to be able to scale it to accommodate your maximum influx of patients, right? So if you think your TAVR program can do 300, 350 TAVRs a year, you're obviously going to try to scale that to do 7, 8 TAVRs a day. How did you figure 7 by 3? Like, I mean, because when you're thinking about your program, obviously, if you can't do 7 TAVRs in a day, but how do you think about efficiency in the context of scaling it to the number of patients you have to treat?
Well, I think there's two things. I think that I don't do routinely 7 TAVRs a day. I probably average 5. There's days when I do 6. There's days when I do 7. There's days when I do 3. But there's much more that happens in a day besides TAVRs. And the one thing that I hate the most is for the team to be there after 5 p.m. because after 5 p.m. we drop to the call team. And if you have 5 cases left at 5 p.m., then the call team is going to be there till 10 at night. And if there's doctors from 2 different groups, there's going to be tension. They're going to be unhappy with each other. And people are going to be sitting around waiting to do cases that should have been done during the day. And so to me, being done on time is critical. And there's much more than TAVR, and you have coronary cases that need to be done. Maybe you have mitral cases that need to be done. Maybe you have, tricuspid is starting. There's going to be tremendous need for the resources that a hybrid room or a high-end cath lab can offer. We're starting to talk about, more fenestrated devices for the abdominal aorta, TAMB, branch devices for the thoracic aorta. Our surgeons do physician-modified endografts. There's tremendous requirements for these scarce resources.
Well, and as you've talked about before, structural heart volumes are going to go up 100% in the next 5 years. Like, we have to be thinking about this now, because whatever number of TAVRs you're doing right now, double it. And that's what you're going to be doing in 5 years. And if you haven't built an efficient workflow for managing that, then you're going to be stuck, and that's where I've struggled recently about going to nurse-led sedation just to take the anesthesiologist out of it. But I don't know, Andrei, Aiden, what do you guys think? Have you guys thought about nurse-led sedation at your institutions? What are your thoughts on that? Because that's kind of the next evolution of this, right? Is super efficient program with an anesthesiologist that, steps out and sees the next patient. But what do you guys think about nurse-led sedation?
I honestly don't have a problem with it. I think in my case, our relationship with the anesthesiologist has been symbiotic. We have open communication channels with them. If there is a problem, I know who to talk to make sure that gets addressed. And we're being in a community hospital where I don't have fellows, residents hanging around. If something bad happens, then I need to have an anesthesiologist in a hurry. That may not always be possible. And I may not get the right person in who knows what to do and who is able to turn on a dime. With the anesthesiologists that I have now, they know our workflow. They come to our valve conference. And basically, when things happen, at least I know that I don't have to manage the pressors. I know that I don't have to manage the airway. And it's definitely not a contrarian or a oppositional relationship. They're reasonable people. They're skilled at what they do. And when things happen, we work very well together. We recently had a guy who I've never seen this after giving local, and basically clearing the pigtail of blood, and probably he got half a cc of dye, he went anaphylactic.
Wow.
And his blood pressure dropped into the 30s, and we did not know what to do because we had just gotten access. We didn't know if he was bleeding, if something had happened. And basically having an anesthesiologist there who managed all that while we did a TAVR was great. And the guy walked out of the hospital, went home the next day. But if you're in a situation like that and you're the physician in the room, it's difficult, right? And there's more and more talk now that they're going to allow for single operator TAVR. You're doing nurse-led sedation and you're the single person in the room with a patient who's crashing is going to be pretty scary if you're especially in a community hospital.
Yeah.
Yeah, I agree. I'm sort of exactly with you. And we have a great relationship with our anesthesiologists. They do, an awesome job. They don't really hold things up. I think, one of the things that I've taken from that grid though is our start times. We're not all on the same page. And I think, but they will certainly get on it if we, make that a point. So, but yeah, I would hate, TAVR complications aren't that common, but when they happen, they can be big, and you still see them, right? If you do 100 TAVRs a year, per 100 TAVRs, you're going to see some stuff that's, it's definitely more than coronary still, I would say. And patients can get pretty sick pretty fast. I wouldn't want to be looking for an anesthesiologist at that time.
That's a good point.
Yeah, and I think that the literature says that the rate of surgical conversion is the same as PCI was 10 years ago. So from that perspective, I think we're pretty comparable. But certainly TAVR has more potential for badness than a diagnostic cath.
Sure.
And I think in terms of start times, I think it's very important to define what exactly the start time is, because in our case, when I say 7:30 start for a coronary case, my expectation is that the patient is on the table, covered in blue drapes, and ready for me to put a needle in at 7:30 sharp. But what ends up happening is that, for instance, in the OR, a 7:30 start means the patient gets on the table at 7:30.
Yeah, wheels in.
That's a very yeah. So basically, we said when we schedule TAVRs, we schedule the TAVR at 7:30 in the cath lab scheduler, and we schedule the TAVR at 7 o'clock in the OR scheduler.
That's smart.
That's a good point, because we've run into that too. There's a disparity between the way the OR and the cath lab schedules. So
yeah, and I'm usually there early, but I think it's the same thing where we don't have a set time, and that some anesthesiologists are a little bit, come in earlier, some later, sometimes they're ready, and then occasionally they're waiting on me, which is not appropriate. I think you got to show respect to your staff, and if you're going to go in on this, and we all do it together, and but certainly, like, we've had patients die waiting for TAVR. So when you get down to it, if you can only do 4 or 5 in a day, and now you're scheduling a month out, these things come in waves. I'm sure you guys see that.
Yeah.
All of a sudden you're scheduling a month out, you got a sick patient, patients can die. So I think that's probably the buy-in that I'm going to take to try to get, my staff and everybody on board to really push on having a really tight schedule.
And you can even get more granular on that, Rainey. Like, I always tell my administrators when I need something that this Malaise paper, 5% of TAVR patients die per month waiting for a TAVR. Like, that's powerful, right? Like, how many patients do you want to die before we can get 7 TAVRs done in a day? And I think people really buy in when you tell them that way. Like, this isn't about some bravado, like, I want to get done in time to go play golf. It's about, like, these patients die waiting for a TAVR. We need to get them in. Let's do it, So.
Well, and I don't know how much this is an issue in your area, but in a lot of big urban centers, if you have a 3 months, 4 months waiting list, patients are going to be voting with their feet. Patients are going to go to the hospital next door, who is going to put them on the table next week. And
especially
that's what's going to happen.
Especially in Chicago, you've got like 30 TAVR programs or something like that, right?
Yeah, no, I mean, we have a lot of TAVR programs. And if, it's kind of like I treat my referring physicians. If somebody calls me up and says, hey, I need this patient seen, they need a TAVR, I'll see them, I'll talk to them, and I'll offer a TAVR generally the following week. most of the time they don't take me up on that because they want to make their own arrangements, whatever. But I always want to have the ability to do that. And the TAVR has become so efficient now that even if I have, let's say next week I have 6 TAVRs on the schedule, can I add a 7th? Sure. Can I do one quickly on Thursday morning? Wednesday is my usual TAVR day. Sure, I can squeeze in Thursday morning, or I can squeeze in Friday morning. So I always want to have the ability to accept a patient that needs to be done quickly. And the other freaky case that we had this Wednesday, one of my partner calls me up and says, "Hey, you got this guy scheduled 2 weeks from now. Can you move him up? Because he's got critical aortic stenosis." He had like a mean gradient of 80, I think. And we move the patient up a week early. We bring this guy 1 week early. We put him on the table. We cross his valve, and he fibrillates. He basically, it's
Carabello.
his
Carabello.
Yes, yeah, Carabello sign on the table. And everybody's doing their thing. I'm looking up at the monitor. I'm like, "Hey guys, can we shock him?" So the guy did great, but had he been another week at home, we might have lost the case and the patient.
Yeah. I mean, you forget what an aortic valve area of 0.4, like what that actually means. Like when you put a 6 French pigtail across their valve, that's pi r squared, man. Like that's
right.
Be plugging it.
2.14 of their 4 millimeters they have. So that's crazy, dude.
Yeah.
Awesome. Well, Andrei, you are the master of efficiency. Thank you so much for this. This was great. And again, we'll put this on the app. People can message Andrei if they have questions about efficiency. Andrei's the moderator for our optimized TAVR channel, and he is the master. So if you have any questions about your own program, please feel free to post them on the app.
Thanks,
All right, Andrei,